So welcome back, everyone. If anyone's a stickler for detail and looking at their program, you're probably thinking, I don't look like a Professor Ian Scott, and you would be correct. My name's Simone, I'm from Uniting Care, and the plan was for me to be purely a behind the scenes person today. I've been part of the event team that's put on the forum, but our facilitator's just a little delayed, so I'm going to get us kicked off. We're on the home stretch. We know there's been a feast of information and ideas and topics here today. The hope is that you sort of pick out the flavours that appeal to your palate and use that to lead what your kind of follow-ups or ideas or actions might be from today. So the session that we're entering now is achieving a more effective health system. Now, I don't have expertise to speak to a really relevant spiel on this, but I think we've already, in some of the presentations and speakers we've heard from earlier today, we've got a feel for what is a fairly logical idea of by having more effective healthcare, be that through preventative healthcare, and then as a patient and a person moves through the health system, by being more effective in how we do that, we cut out low value healthcare. So it's without any further delay, I'd love to introduce our first speaker, Professor Anthony Smith. Professor Anthony Smith is the Director of the University of Queensland Centre for Online Health and a Professor of Telehealth at the University of Southern Denmark. You probably haven't been doing too many work trips there in the last 18 months. Professor Smith has sustained an exemplary international track record in the evaluation of telehealth, principally in paediatrics, adult and aged care disciplines. He has over 210 publications in the field of telehealth and digital healthcare, wowzers, and is one of the most prolific telehealth authors worldwide. Professor Smith is also the Editor-in-Chief of the Journal of Telemedicine and Telecare, which is the leading journal in the field of telehealth. Please join me in welcoming Professor Anthony Smith.
Well, look, thank you very much for the introduction and good afternoon, everybody. My name's Anthony Smith. I'm from the Centre for Online Health at the University of Queensland. It's lovely to Zoom in, although I'd love to be there in person, wherever you happen to be. But before I begin, I'd just like to acknowledge the traditional owners, our Aboriginal and Torres Strait Islanders. For me in Brisbane, it's the Yagara and the Turrbal people. And just like to acknowledge them as the traditional owners and also pay my respects to elders past, present and emerging. I've been involved in telehealth, as Simone mentioned, for over 20 years, and telehealth has been around for a long time, despite many people trying to raise the flag and say they've discovered something new. Telehealth has been around for a long time, and the more you talk about telehealth, the more you realise that telehealth is really an excellent way of us improving the way that we provide healthcare services, and there are certainly environmental benefits to follow. So my centre is based in Brisbane. It's physically based on the Metro South campus along Cornwall Street near the PA Hospital. As I said, but we've been around for over 20 years, and much of the work is designed around improving healthcare and creating stronger communities simply through the use of telehealth, and that takes many shapes and forms. Since 1999, we've gone from a small team of about 2 or 3 people up to about 27 people now. We cover a whole range of different areas. I think what makes our centre particularly unique is the fact that we've got a team of people with a whole range of different backgrounds. Everyone contributes something quite unique. Many of us have clinical backgrounds, which gives us a little bit of a closer eye and understanding on what actually happens in the health service. And when we're trying to change the way that we work or encourage people to think outside the box, it's always good to kind of understand what they're thinking. Our centre covers a whole range of things. Obviously, being a university centre, research is very important, as well as teaching, but we also provide services and do consultancy services. We have partnerships with Queensland Health, different health service providers, including Metro South. We've got our hands dirty and delivered many consultations. It's about 100,000 now since COVID, so many consultations for lots of different clinical disciplines. So if anyone doesn't believe that telehealth has a place in the health system, I think you're wrong, and I'd be happy to argue that one a little bit later. But we also run a conference called Successes and Failures in Telehealth, and It's a really good conference if anyone wants to get there and learn about what works and what doesn't. It's a really good way of sharing that experience. I haven't got a lot of time to talk, so I'm going to fly through this pretty quickly and just talk about some examples of how telehealth is used. And things are rapidly changing. And if I compare what's happened 20 years ago to what we're doing now, completely different in terms of the technology, some of the user requirements, and some of the different applications which have been brought about thanks to new funding. There's a lot of talk and a lot of effort being put in around the world to actually create hospitals that don't necessarily have hospital beds. They're virtual facilities providing only virtual care, supporting networks of people around the country. And these services are getting fairly well highly profiled, mainly around the US, Canada, and more recently in Australia with our digital hospital systems. There's also a lot of work happening in the remote monitoring space. It's rapidly changing the way that we provide care. And there's also a lot of work happening with hospital in the home. So getting people out of facilities, out of hospitals into the home and being able to provide care is easily done, or I should say it's sensibly done with the use of telehealth in most cases, but not all. So we've been involved in a lot of different clinical services over the years, which has been fantastic. We've worked closely with clinicians and developed these new services in the pediatric, adult and aged care environment. And I just wanted to go through a couple of really simple examples to show you how things are really changing. So in diabetes care, if you think about routine appointments for someone with diabetes, chronic health condition, having many appointments coming backward and forward to see the specialist or a diabetes nurse educator or another member of the allied health team, we're also now looking at remote monitoring our patients. So instead of bringing them into hospital, setting them up with remote patient monitoring at home or even via their own phone. And having smart dashboards set up where we can monitor information, clinical information that will alert us to anything unusual, and anything out of the ordinary can be sent with an alert to the dashboard and monitored by an appropriate staff member, and then we respond as we need to. And that triggers a response from someone in the diabetes team. If there are any complications or something needs to be handled where the patient does have to appear, then they do come in, but it's definitely reducing congestion in the outpatient department. So we're slowly seeing a change of a busy outpatient department full of people with diabetes having 5-minute consultations with their specialists by now using remote patient monitoring, telephone and video links into the home as a way of providing better care. Think about aged care. You know, there's limited access to specialist services, and this is a bit of a tricky one. It's hard work working in residential aged care facilities for a number of reasons. But typically, if a patient needs to see a specialist or be transported, that happens at not only high expense, but huge stress and inconvenience for that patient and often the family. So what we're doing now is providing video consultation into these facilities to provide the care to patients so that they don't need to travel. Much of this care can be handed over and supported with a primary care provider or a nurse in that facility. And that saves everyone a huge amount of time and inconvenience. Part of the real challenge in actually doing this, it seems like a no-brainer, is the fact that we're really struggling with workforce, making sure we've got not only the workforce, the bodies on the ground in the facilities to do the work, but also that they're trained appropriately to do telehealth and that the available infrastructure is in place. The infrastructure side of things is getting better, but the staff and the workforce remains a challenge. In dermatology, many referrals often require a patient to attend in person to see a specialist dermatologist, but we're now realizing huge benefits in actually being able to just send a digital image to an appropriate specialist to form an opinion, or at least indicate whether the condition is urgent and needs follow-up care. So if you have a chronic condition, such as a recurrent rash or another skin condition, that means regular appointments with a specialist. Telehealth can be used by simply sharing these images, and they're often done by either a secure email system or over the web in an online portal. And this is a great way of actually visualizing that lesion and then being able to provide some advice. There's growing evidence now to support the clinical efficacy of these models, and they are being used in areas. One of the major reasons why these types of systems, which seem obviously so useful, haven't really got off the ground to date until now, is the fact that there haven't been any proper funding mechanisms to follow them. And in Queensland Health now, there is funding for occasions of service that will support these types of consultations. Now, in terms of the topic, the environment and the benefits of the environment, Some of the obvious things about telehealth is that you're not actually getting in a car, bus, plane or train and traveling for your appointment, and that must save some money. So just want to highlight one example from a group of colleagues that I work with in UC Davis in Sacramento who wrote a paper. Now this paper reported on about 20,000 of their consultations, and they estimated about 5.3 million travel miles were saved as a result of their telehealth work, which is about 4.7 million minutes or 8.9 years of travel time saved, and about $2.8 million US dollars saved as a result of reduced travel need. The other interesting thing they did work out there was the fact that they calculated their number of their carbon savings, and their carbon savings are close to 2,000 metric tons. In our work in telepediatrics in Burns, we did a similar paper. We looked at actually the travel distance that was saved. So kids would typically be looked after in Brisbane, but we set up a model where we could actually use telemedicine to support the patients instead of them all having the travel. Now, this is quite interesting because, again, just going down the angle of reduced travel requirements, over 14 years, we delivered just under 2,000 consultations in paediatric burns alone, calculated the distance that would have been travelled if people did have to travel for their appointment, and worked it out to about 2.8 million kilometres. Now, 2.8 million kilometres sounds like a big deal, and it certainly is. Just to put it into context, something slightly easy to remember, it's equivalent to 4 return journeys from Earth to the Moon. So during COVID, big talk about telehealth. Telehealth has become a household name. Of course, telehealth has a key role during COVID. Social distancing requirements. Telehealth is perfect because you're not in the same room in the same place. It helps us keep clinicians safe. It also helps us keep vulnerable patients safe. And of course, in line with that, there are environmental benefits we need to think about. So one of the driving messages we have now is, as we move out of COVID, hopefully, we want to make sure that telehealth remains. This is just interesting for those who are interested in what's happening as a result of COVID. This is the MDS data. Now, before COVID, just to give you an indication of growth, there were about 270,000 telehealth consultations that were funded by MBS. Post-COVID, about 62 million, admittedly, most of these telephone consultations. So moving on, we do hope that telehealth will continue, and we expect it to. There are a number of requirements that are highlighted in this paper: building a workforce that is trained and ready to deliver telehealth, making sure consumers know what telehealth is and ask for telehealth, making sure that funding is available to fund all the components of telehealth, improving the digital ecosystem and making sure we don't walk around with a pocket full of passwords, and also making sure that telehealth is properly integrated into routine practice. So just to conclude, there are a number of resources that you may find useful, including a reference to the SFT conference. The journal is also available online if you'd like some more information about telemedicine and telecare. Our centre website has information about all our projects, and also a link to the Australian Telehealth Society. And of course, everyone next year in November will be available to attend the SFT conference. It will be held in Brisbane. So maybe mark that in your diaries and come along and learn more about telehealth. So just to finish, telehealth is a disruptive process. What I strongly believe in is people should stop for a moment and think about how they provide services to their patients and think, is this really the best way of providing care? So telehealth is transforming care, and if we do it well, we're going to create a much more efficient health service. We're going to be designing and delivering more patient-centric services, and for all the reasons I've explained so far, we're going to have a much healthier environment. Thank you.
Thanks very much, Anthony. And just to introduce myself, I'm Ian Scott, Director of Internal Medicine at PA and Profit Medicine at UQ. It was my pleasure to facilitate this session, but I was a little delayed from PA, so I won't bore you with the details, but I'm very pleased now to be here, and I'd like to thank Simone for stepping in and facilitating the session at the beginning. Anthony, that was a great talk, and we have a new benchmark, the Earth to Moon return journey savings, so we'll keep that in mind going forward, so thank you for that. We'll just hold questions until the end. We'll have a Q&A session at the end, and we welcome you to enter your questions into the Slido, and we'll have a look at that at the end. And please, we'll welcome you back then, Anthony, to talk further.
Thank you, Ian.
All righty. We'll move on then to our next session. We have a dual act now, 2 speakers. We have Dr. Lana Bastakis, Lana is a consultant anaesthetist with a special interest in obstetric medicine and retrieval medicine, and she's currently completing a master's degree in perioperative medicine. And she's going to be joined by Anna Petch. Anna is an anaesthetic senior medical officer at the Sunshine Coast University Hospital, also has a special interest in perioperative medicine and sustainability in healthcare. And they're going to be talking about how they see the new world of preoperative pathology ordering. So thank you very much.
Thank you very much for inviting me here to speak today. And I especially want to thank Lana for nominating me to speak on behalf of both of us. So thank you. Before I start speaking, I obviously want to acknowledge the traditional owners of this land, which on the Sunshine Coast for us is the Gubbi Gubbi people. So we're here to talk about preoperative pathology ordering. And I'm really sorry to let you know that I haven't got any cool maps of going to the moon, but I have got a map. So strap yourselves in. I'm not going to talk a lot about this slide because I think that I'm really preaching to the converted about the fact that we can't continue to ignore the CO2 emissions that we create through healthcare. Importantly, this document brought to us by the NHS gives us some really practical solutions. But the thing that I heard today and the thing that really stuck with me is the most sustainable hospital and the most sustainable healthcare is the one that we don't do. And that's where our project comes in. So how can we actually think about what we're doing and actually prevent creating the waste? Because I think we've all heard some really good solutions about waste. And our project is going to look not only at medical equipment, but also looking at patient travel. We're here partnered with Choosing Wisely. And for people who haven't heard about Choosing Wisely, it's an Australia-wide initiative that allows us, as the words say, to choose wisely. And what's important about choosing wisely is that in healthcare, sometimes more isn't better, which comes as a shock, I know. Reading through those points there, the thing that's really stuck with me is that up to 90% of pre-surgical patients have at least one unnecessary test ordered. This is just within the pre-surgical environment. So I know that people work across huge, different areas, environment and in medicine. Think about, the cost and the on cost of that throughout all of the areas in which you work. And we know that pathology essentially is a huge, huge drain on our healthcare system. And you can see there for the year 2018 to 2019 that it was about $3 billion just in pathology. So what did we do? So I'm the lead of the pre-anesthesia evaluation unit, which means that I see patients before they have surgery. We had a very complex system for doing blood tests, which involved the surgeons creating a protocol, the nurses in my clinic handing out a form, and then me checking the bloods. So no one really owned that process. And I had an inkling that we were doing a whole lot of bloods, which are really low value intervention, that potentially were very far away from evidence-based practice. So we decided that with an inkling probably wasn't enough to create change and that we needed to do an audit. We looked at all the surgeries that occurred over a 1-month period across all surgical specialties. We compared the blood tests that were done for these patients to evidence-based guidelines, and this was a total of 527 operations. What was important to us, though, was to also have a look at the outcomes of these blood tests. So were there interventions that were occurring as a consequence of these blood tests happening, or were we just doing the blood tests? So what did we find? I hope that this comes as a shock to you all, because it came as a shock to me. We found that for some departments within our hospital, so starting on the right-hand side of your screen, for example, with urology, and focusing on the blue bar is comparison to SWAPNet, which is essentially our evidence-based preoperative blood tests, which correlates with the NICE guidelines in the UK. So for urology, for more than 75% of the elective surgical cases, we were doing blood tests that didn't need to be done. We weren't correlating with what we would call our evidence-based guidelines. As you move across the screen to the left, you can see some departments that were more compliant with evidence-based guidelines. And what was also interesting to me was the red bar, which is the departmental protocol, the protocol that our surgeons had written. We also weren't actually doing the blood tests from there. So where were these blood tests coming from? The other thing of interest was that we found from those 527 operations, there was one intervention that occurred as a consequence of the blood tests. And that was an iron infusion that happened in a patient who happened to be missed by our anemia screening pathway. There were also 2 patients who had repeat blood tests done on the day of surgery because they were abnormal. So you can see that there's a lot of room for change. Thinking about the impacts, because that's pretty important here today, and we're going to talk a little bit about the financial costs and also the environmental impacts, but the manpower costs sometimes are just astounding. So for every blood test that we did, someone had to print the form out, give it to the patient had to go and have the blood taken. Someone had to take the blood, process that, put it onto a computer for my anaesthetic registrars to then read the result and then sometimes, phone back and follow that up with other departments. It meant that patients within this huge geographical area sometimes had to drive from Tin Can Bay to Gympie to have these blood tests done. And I don't think we can overshadow sometimes the impacts that this can have for patients in distress, but also in having false positives found. Financial costs. So I think there's a few health administrators in the room here today. So over a 1-month period, this table shows you that just within the Sunshine Coast University Hospital and just within elective surgery, we did $9,000 worth of tests that didn't need to be done. That correlates to $109,000 worth of tests in 12 months. And you might be saying to yourself, as the orthopedic surgeon said to me, it's just a couple of joints, who cares? This is the tip of the iceberg, right? So this is just elective surgery. This isn't post-surgery. This isn't in the emergency department. This isn't on the medical wards. This is really, really, a really small representation of what we're doing within healthcare. And thinking about the environmental impacts, so Forbes McGain, who's really the rock star of anaesthesia and recycling, published this article in the Medical Journal of Australia in 2020. Having a look at what the environmental impacts of blood tests are. And it probably won't come as a shock to anyone in the room that really it comes down to the consumables. So the ability to change the energy that we get, to change the tubes that we use, to reuse and recycle the things that are actually contaminated is really difficult. So looking at consumables is important. Or as Lana and I want to tell you, not doing the test is also pretty important, hey? And I feel a bit sad about this slide now because my car doesn't go all the way to the moon. But looking at the CO2 emissions over 12 months of unnecessary pathology, and remembering that this is just within my clinic, and this doesn't include the group and holds that we did throughout this time. Oh, the car didn't drive. That it would be a car driving from here to Cooktown, which, as I said, isn't from here to the moon. But I think you can understand that if you took that out over the $3 billion worth of pathology spent by Medicare, across Australia, that probably that car would get to the moon. I'm going to sigh here because for anyone who's tried to enact change within healthcare, you know how difficult this is. There's a lot of stakeholders involved. And sometimes I feel like I'm at the bottom of a mountain trying to stop boulders rolling down. So what did we do about this? We decided to pick off the areas that we thought would have the biggest value. And if you remember from our graph, that was urology. We're meeting with the departments one by one, and we're redesigning their pathology protocols. And we're doing that with an evidence-based background so that each department essentially will review their pathology that they do for their patients coming for surgery. Obviously, we're going to go back and re-audit, and this re-audit's actually been a real eye-opener for us because it's really let us know about what the priorities are for each stakeholder. For the surgeons, they just want to do the surgery. For the nurses, they just don't want to do anything wrong. They don't want to get in trouble. They don't want a patient not to get there. And interestingly, it's been the anaesthetists who are actually quite conservative in needing blood tests done. And although we're not all the way there, we can proudly say that after re-auditing our urology bloods, we've moved from a 23% pre-intervention compliance with evidence-based protocols, and we're up to 69%. So we've still got a lot of room to move, but really we've eliminated a huge number of blood tests just over a really short period of time. Moving forwards from here, we have partnered with Choosing Wisely, and we are actually speaking nationally to other hospitals in the hope that we can also institute change within their pathology. And in fact, we were inspired by a group down in Hobart. We're speaking within our hospital to other departments like rehabilitation and interventional radiology who really want to review the blood tests that they're doing as well. And as an anaesthetist, I can say anaesthetist, but also, as I'm sure you're aware today, being an anaesthetist from the Sunshine Coast University Hospital is a pretty proud position to be in, and that we have the ability to really enact change in so many different areas. We're really aware of ditching the DES, and we're well on the way to that. And so hopefully we can help move towards a greener and sustainable healthcare system. Thank you.
Thanks, Anna. I think you've made a big change, tripled from 23 to 69. That's not bad. So in the discussion, we might hear more from you, just exactly how you did that. For our next session, I'd like to welcome Associate Professor Martin Henscher. Martin is Associate Professor of Health Systems Financing and Organisation at Deakin University and also Deputy Director of the Deakin Health Economics Group. And his current research includes evaluation of telehealth and digital health interventions and how we can reduce low-value care and minimise our ecological footprint. So welcome, Martin, and we look forward to your talk on understanding the economics of sustainable healthcare systems. So thanks very much.
Thank you very much indeed. And I would also just like quickly to acknowledge the Wurundjeri people of the Kulin Nation as the traditional owners of the lands where I am today. I'm a health economist. Health economics is all about microeconomics, but I want to just take a slightly different tack today and talk about the wider macro picture, the wider economics in which the future of healthcare is embedded. And it's worth just remembering that modern healthcare systems are completely a product of the very recent history in which we've been in this period of extraordinary economic growth in the last 250 years or so, in which all of our modern healthcare systems have emerged, and really in which all of the change and gain in health status has also occurred. And in our own lifetimes, we can see that healthcare is actually deeply linked and related to economic growth, because in fact, healthcare systems have grown faster than the economy for a good 50, 60, possibly even longer years. So healthcare is all about economic growth, but there's possibly a problem there, two problems in fact. The first is that actually for decades in the rich world, economic growth rates have actually been slowing. Every decade, growth is slower than in the decade before. And as many of you here, I'm sure, are all too aware, at the same time, all that economic growth that is behind us, that history of growth, has pushed us ever closer to and perhaps beyond planetary boundaries. It's created what Herman Daly, the ecological economist, called a full world, where we have filled up the world with our production and our consumption, ourselves, our livestock, our materials, pushing us into ever greater environmental risk, not just climate change, many other environmental impacts and risk factors. And it's really important for us to remember that. So much so that many have suggested that the period of economic growth is now perhaps becoming what some have called uneconomic growth, where in fact the costs, the harms of increasing production in the economy are actually starting to outweigh the benefits of that increased production. And a group of economists called ecological economists have started developing a quite different perspective on the economy and on economics. Traditional economics is essentially concerned about the optimal or efficient allocation of scarce resources. But ecological economists also think we need to focus on two other factors as well: just distribution, but also on the sustainable scale of the economy relative to the ecosystem. So literally, how big can we keep our economy and survive with the ecosystem intact? And my work over the last few years, or part of my work, has been trying to apply ecological economics to health and healthcare systems and issues, and try and understand what perspectives that can bring. Now, I think almost everybody here, as others have already said, preaching to the converted, you all understand the many different kind of impact routes that healthcare systems have to have harmful impacts on the natural environment, and from there, potentially back onto human health. So clearly one aspect of what we need to do to understand the economics of sustainable healthcare is, in that more traditional way, absolutely to think about efficient allocation of resources when we include environmental impacts. We absolutely understand we need to minimize waste, minimize resource use, all of those things, of course, and that if we can minimize resource use, we will reduce the costs of production. But also, we need to work towards what economists call internalizing the externalities, the externalized environmental harms of the healthcare system, and try and bring those costs of those harmful impacts back into our economic decision making. And that is, I would predict, going to start happening in the next few years. We can't talk about carbon pricing really at the moment in Australia, but I would suspect some form of carbon pricing will definitely come, and that will impact on the prices you face in the healthcare system for the resources that you are buying. And at the same time, while health economists have been a bit slow coming to this party, we are now, and myself and a few colleagues globally are starting to look at how can we incorporate environmental impacts into the economic evaluation of healthcare to internalize those costs. But we have to be very careful, because the ecological economists give us another insight, which is that there's a big risk in lots of settings, lots of industries. When we increase efficiency, we reduce resource use, we make things cheaper, and when we make them cheaper, we can easily, all too easily, end up consuming more of them. So sometimes our efficiency improvements can actually become counterproductive if we're thinking about environmental impacts, if we end up consuming more. So we need to be very careful. Technical kind of greening is not enough. We've also got to particularly think about the scale we're operating at and whether we need to keep that scale under control. And we've understood for decades, since the work of Donna Bedian on quality and safety, that actually healthcare does display what we call diminishing marginal returns. Initially, more healthcare gives us lots of benefits, but after a while it gives us less and less, and maybe beyond a certain point, more healthcare actually causes harm. And that's true at the level of individual patients, it's true at the level of systems, and it's true at the global level. And some of my work has looked at spending, health spending and health outcomes across countries. These graphs all show countries, global spending and global health adjusted life expectancy. And when we get into this data, we can see very clearly that you get huge benefits from increasing expenditure from low levels. Then those benefits start to slow down, and eventually at high levels of spending in the rich world, maybe flatten off, possibly whisper even, maybe become counterproductive. So we need to think hard about what's actually the optimal level of provision of healthcare in a society, not just public, also private, the whole healthcare system of a society. What we also increasingly understand is that there's an intimate link between overconsumption and harmful consumption in the rest of the economy and in what happens in the healthcare system. And a really interesting insight which is emerging is a concept called failure demand, where we get failure demand for healthcare, which is avoidable and undesirable demand for healthcare coming out of both overconsumption of all the many health damaging things that our economy likes to sell and put into people that cause harm to them, that causes them to demand healthcare that could have been avoided, whilst within our healthcare system, as I think many people have said in presentations today, poor quality, overuse, overdiagnosis, overtreatment, or overconsumption in the other language, themselves drive cycles of failure demand. So we need to get in and break these loops and cycles of failure demand between the rest of the economy and the healthcare sector if we want to get control of demand for healthcare and make it sustainable. So the implications of this for the economics of healthcare in a sustainable world, I think can be summarized deceptively simply. Of course, the work behind this becomes endless, but we are probably in the rich world moving into what some have called a post-growth world. And in particular, our healthcare systems are not going to be able to grow in the ways that we've been accustomed to, not only because we face environmental constraints, but actually because the economic growth is not going to be there behind them to provide the resources to do that. We recognize now that a significant portion of healthcare yields little or no benefit and causes harms to human health, in fact, in many cases, and that all healthcare, to some extent, causes some harm to the natural environment simply by consuming resources. So we've got to act on them and improve our efficiency in that space. We've also got to recognize, though, that many of the world's poor, billions of people, have grossly inadequate access to healthcare, yet in the rich world, maybe many of us actually are consuming more healthcare than is actually beneficial to us. So we're going to have to move healthcare systems to become much more environmentally efficient, to minimize their impacts on the environment and their harms to human health. But remember that we can't just be efficient, because sometimes efficiency drives increases in use. So we've actually got to start now thinking about sufficiency. What is enough healthcare? How can we actually meet the needs of populations and do enough instead of doing everything possible? And I would suggest that's the biggest challenge here, is to develop a culture of sufficiency across healthcare where we're trying to do enough and do it really well. And if you're interested, there's a few publications here when the slides are made available for those who might be interested. So thank you.
Okay, thanks very much, Martin. Easy solution that you've given us there. I'm sure we can implement that tomorrow. But I think there are some very important points that you've made, and perhaps we could now open it up for a bit of panel discussion. So I'm just going to move over here to this microphone. Anna, perhaps you'd like to come down and join me, so I'm not here by myself, and also Lana too. So just let's make sure that our panelists are online. Martin?
Yeah, I can hear you.
Yep, I can
Anthony?
hear you too. Yeah.
Okay, good, excellent. All right, the microphone wasn't working. So perhaps I could start with you, Anthony. You said that a lot of those telehealth consultations were actually telephone.
Yes.
So if we want to really sort of ramp up telehealth, what do you think are the major barriers? Is it just funding, or is it because many of our folk perhaps can't really handle the infrastructure, or the ecosystem isn't well developed? I mean, if you had a magic wand, what do you think would be the one major thing that you'd change to really get telehealth going in a big way and sustain it?
Gee, I wish it was that simple, Ian. I think in terms of telehealth happening, there's a lot of work happening by phone. I mentioned 92%. That's reported activity through Medicare. It's not really about infrastructure, although some argue that having multiple systems doing different things and difficulty in scheduling is often one of the challenges. But Medicare funding was introduced for telehealth with a very open rule, very relaxed conditions during COVID, and that meant that telephone and video could be done. So the natural, easiest process that people find is to pick up the phone and to call the patient and to do a consult. But for those who have done telehealth will appreciate that, I guess, having a video included in the consultation adds a huge amount of content in your ability to view the patient and pick up some non-verbals and even do some physical assessment and remote assessment. So there are certainly cases that telephone lends itself perfectly fine, you know, but having video, I think, adds a lot. I think one of the big challenges is time and coordinating a telehealth session, and the fact that it needs to be done at a time where the patient and the specialist or doctor is available, or a nurse. That's often one of the difficulties. And doctors, particularly in primary care that we've talked to, asking the question about why phone versus video, often blame either internet connectivity, which is usually not true, or they just say it's mainly convenience. It's much easier to pick up the phone and call them than to try to muck around with the system and spend 5 more minutes making it work. So I guess to answer your question, I'd like to see a seamless infrastructure where we could contact people in the same way that we simply pick up the phone and call someone, where we don't have to worry about multiple video conference platforms. We don't have to worry about our pocket full of passwords, and make sure that all the information that we need to make a good clinical decision is available at one single point of contact.
Okay, all right, thank you very much. So sort of seamlessness with respect to the ecosystem. All right, I know that we have to wrap up shortly, so I want to give every one of our panelists a chance to answer a hairy question. So Anna, you obviously had a trebling there in relation to compliance. So what do you think, what really made that happen? Was it just simply making people aware of the fact that they were not being compliant to start with, or were there some other more sort of deep cultural changes that you had to undertake to really get change?
Yeah, I think deep cultural things is probably some of the answer, but also I think probably a lot of it, as I said, just wasn't based on evidence. So it was actually us going to, our colleagues and actually presenting the data. So I think that's one side as well, to show how far off evidence-based we were, but also talking about the evidence and the why we were actually doing the blood tests. And so we actually presented a lot of evidence. For each surgical specialty we visit, we work out what we think their concerns are going to be. So for urology, for example, we talked about gentamicin and kidneys. And so we kind of unpacked the reasons that we thought that they were doing blood tests, but also I think it's been around education and engagement. So we actually have sat down with them. We've looked at the way they classify, the surgeries, and actually have allowed them to kind of own it as well. And I think that's been really critical. We think the gap we currently have is probably just in education and promotion, which isn't surprising. We feel like we talk about this all day, every day, but for a lot of people, they haven't heard of it. So that's kind of our next goal, I guess, is going back and a bit more education and engagement, especially with the nurses in our clinic.
Yes, thank you. So for us, like low value healthcare, we're lucky that we have a macroergonomics, the mesoergonomics of our hospital are such that we have an organization wishing to engage in sustainability in healthcare. So we have champions in our organization that are wanting to help us implement change, and we have warriors, champions, eco warriors who are hoping to help us out. So local leadership is excellent, and that's really helped us move forward with our project.
I was thinking too that in many respects, is it just simply a matter of trying to get hold of blood tests that have already been done by a general practitioner? Is that
Yes. And I guess that's one of the things is that we were finding is because people just want to follow the protocol. If the protocol says they need a blood test, Doesn't matter if they had the blood test 3 minutes ago somewhere else, the blood test had to be done. So that's the other thing we've negotiated, is looking at timeframes. And in fact, our timeframe's 2 months. And this week, one of the nurses came up to me in clinic and said, it's 2 months and 1 week. Can we skip the blood test? So we're getting there. It's like really small gains.
It's good to hear. Martin, perhaps we can come to you in the big macro picture. And that is, well, how do we actually create this very broad cultural change? It seems to me that we really have to undertake some fundamental reforms of our economy. If I can be controversial, perhaps the capitalist model has to be seriously looked at if we're going to sort of minimize overconsumption and wastage. So how do you see that actually happening? Because I think our political leaders are a bit slow off the mark, and I think in the whole global climate change movement, they're probably in many instances behind what economists and what industrialists and the community generally feel about this. So how do we get the cultural change?
So that is a fantastic and horrifying question, but at the big level, I think what kind of people in various movements, sort of ecological economists, well-being economy people, there's various names for these things, but there's a lot of consensus in particular that all countries need to move away from focusing on gross domestic product and growth in gross domestic product, which is what we mean colloquially when we're talking about economic growth, as an official measure of the economy, but also, and this is more challenging, really in the media and in our kind of economics reporting in the media, we're always focused on GDP growth, what's happening, recession, etc. So countries like New Zealand, Scotland, Costa Rica, Iceland, various places now are making a very deliberate effort to focus not only their strategies, but actually all of their kind of performance measurement and accountability away from GDP type measures and onto human well-being, environmental well-being type of measures, etc. So that's one area. A second area is the kind of work that Mariana Mazzucato and others are doing at the moment, which is about really recasting the relationship between the state and the private sector and industry, and accepting that we're not going to solve any of these problems if we simply leave it to industry, because whilst the private sector is incredibly innovative and is in coming up with amazing inventions, it is driven inexorably by profit. And if what we really need is people to make less and consume less, which is what it really boils down to, we actually need quite different forms of regulation of essentially how most aspects of private sector industry operate, so that there's still room for all the dynamism and innovation we get in the private sector, but that it's directed and regulated quite differently by states towards kind of common societal goods. And I think that's that's kind of the more technical end. I think the third level is we just all have to try and demand very different approaches to economic policy from our politicians of all kinds. We need to ask for that. We need to use our role, as people are doing very successfully in the health sector, but also to mobilize others and not just focusing on health. This is about the whole show.
All right, well, thank you, Martin. That's a great note to finish off on. We have an election in 2022, folks, so I think we have an opportunity to indicate to our political leaders what we really think. And I think it is important that we really do now in the healthcare sector use our professional status and our credibility in the community to really push this agenda of reducing low value care, which also then has a benefit for our environment as well. So I'd like to just thank all our speakers today. I think we've had a very interesting session. We've come away with some new ideas, and we now have an agenda of change that we should all try to pursue going forward. So thanks to our presenters and to everyone else involved in putting on the session today. Thank you.